So we all know among the causes of infertility, 30% of the infertility issues are due to female factor. And so let us plan the female partner's infertility journey in a systematic manner with the help of good practice guidelines and evidence-based medicine. So we all know when to call a couple as infertile. Yes, when there is failure to achieve pregnancy after 12 months of regular unprotected sexual intercourse. So does this hold for all the couples? According to ASRL, so the evaluation has to be started, or the couple is said to be infertile after 12 months of sexual intercourse if the woman's age is less than 35 years. So the evaluation has to be started even before, in case when the female age or woman age is equal to 35 or more than 35 years, it is after 6 months of failure to achieve pregnancy or failure of treatments. And immediate evaluation is when woman age is more than 40 years, irrespective of duration of infertility. And site 20 days or menorrhea, we need to evaluate the couple. And they are not expected endometriosis, and when there is no suspected male infertility issue, yes, we have to evaluate. And also when there is sexual dysfunction, when she has complaints like vaginismus or dyspareunia, or the male partner has erectile or ejaculatory dysfunction, yes, we need to evaluate the couple. And when the partner has genetic causes which leads to diminished ovarian reserve, that is when the family has a ferment mutation that is running in the family, yes, we need to evaluate her. And any acquired conditions can lead to diminished ovarian reserve, like previous surgeries on the ovaries, or she has undergone surgery for ovarian endometriosis, or she has undergone any chemotherapy or radiotherapy for malignancy, yes, we need to evaluate. And when the couple has history of recurrent pregnancy loss, irrespective of duration of the infertility and age of the patient, yes, we need to evaluate. And if the female partner is a carrier of particular mutation, one needs to evaluate the other partner, whether he is also carrier for that particular mutation, we need to evaluate. And evaluation of both partners should begin at the same time. At least for the male partner, the history and semen analysis report should be there. And coming to evaluation part is the history. I mean, one need to identify the risk factors for infertility, whether she has any ovarian reserve or any uterine factors. One need to recognize from the history. So the fertility history, one need to ask about the whether she has undergone evaluation previously, whether she is carrying records. One need to thoroughly go through the records, whether the ovulation induction was done with a particular agent, whether gonadotropin was used, and whether ovulation has occurred or not, and the tubal factor has been evaluated or not. One need to go through all the things. And regarding the gynec history is menstrual history. One need to know whether her cycles are regular, and whether she has any dysmenorrhea with dyspareunia, which can point towards a particular pathology. And we need to ask her about the previous history of pelvic inflammatory disease, whether the patient has previous lower abdominal pain with leukorrhea and leukocytosis. Yes, one need to rule out because the PID can lead to tubal factor infertility. And regarding the obstetric history, yes, one need to ask about whether she has any miscarriage, whether it is biochemical or clinical miscarriage, because in case of RPL, we have a number of causes that need to rule out from the genetic, vascular thrombotic causes. So one need to thoroughly ask whether the clinical miscarriage has occurred after the appearance of cardiac activity. And the obstetric complication, yes, as we are preparing the couple for this pregnancy, so any prophylactic measures that can be taken in the early pregnancy to prevent those complications. And congenital birth defects, is there any syndrome or the recurrence in the subsequent pregnancy, we one need to evaluate. Yes, the medical history, yes, whether she has undergone any chemotherapy or radiotherapy, and the surgical history of any surgeries, endometriotic surgeries or surgeries done for twisted ovarian cyst, which can point us towards the chance of diminished ovarian reserve for the particular patient. And regarding the family history, certain of the autoimmune disorders which run in families or immune endocrinopathies one need to evaluate. And the birth defects and history of premature menopause, that is menopause less than 40 years in the mother or in the siblings, one need to know. And social history, regarding the social history, yes, with obesity, we know that disturbance in the endocrine system, which can lead to ovarian dysfunction because of decreased lead secretion. There could be a short luteal phase, and because of inflammation associated with obesity, there is increased active options which affect the folliculogenesis. And in IVF, it is found that obesity is associated with higher and constellation cycle and also low cycle. Smoking, active smoking have an effect on fertility. And as it has the tubercular glands to infertility, shall increase the risk for ectopic pregnancy. And it also decreases aromatase function and as it disturbs the meiotic and even it avoid and so that with moderate conventional it is found there is increased levels and decreased progesterone levels. And stress factors there is increased cortisol levels, which inhibits the release of GnRH released from hypothalamus. So one needs to general examination from head to toe and any